in this presentation on the top right hand side.
Okay, thank you, Robbie. Welcome and good evening, everybody. It's great to be here. It's strange looking at Robbie Williams only and nobody else, but that's a pleasure. Could be look at worse things. I'm going to get on with things here because I'm going to talk lots and lots about cases. My presentation, as you'll see, will be very much driven by photographs. I've spoken to Robbie a few times regarding who's been invited tonight. So hopefully you'll get a sort of a grand sort of view of what I do in sort of general practice. I am a general dentist working from a practice in Hoylake. I opened it about 4.5 years ago. I sold it two years ago because I just couldn't cope with the amount of work that was coming in. It was busy and busy, and I think what became quite apparent to me was the fact that, you know, I'm a clinical dentist. I do want to stay clinical, and my weakness is probably more to do with the running of practice. So what's sort of the benefit of it is of me selling the practice was that I can look after myself. I qualified Liverpool 21 years ago this summer, seems a long time ago, and I was in partnership in Thornhope with Ian Buckle for a few years. So I left that partnership and I opened the practice, as I said, 4.5 years ago. I am a general dentist and I haven't really had very much formal postgraduate training. I've traveled the world. I've done lots of different courses. I sort of went from one practice or one sort of avenue or one speaker to another. I would sort of see various people I liked what they did. So wherever they were in the world, I went and I observed what they did. I learned what they did, and that's how I went forward with myself. So I'm very much proud to be a general dentist, and you'll probably see from tonight that my cases are very much across the board. I don't just do implants as people sometimes think I do. I do a lot of restorative work, and I would say most of my work over the last few years has been more complex restorative combination with implants as well. So that's exciting. I like that type of work, and that's what that's my passion. So in order to get your CPD tonight, we've had to do some aims and objectives, and it's basically to introduce or provide practitioners with an insight to providing treatment to all our patients with an aesthetically acceptable outcome, regardless of the treatment. That means that we must plan, look, have a vision of where we want these teeth, how we want teeth to look, whether it's a denture, bridge, crown, veneer, it doesn't matter. I still believe that we can modify a tooth to the general shape it needs to be. So if it needs some combination work, then that's fine. We need to do that. A big aspect of my work is sort of looking at where the teeth are, and not just the teeth. More as importantly as the teeth is certainly the soft tissue. The soft tissue is a huge aspect. I notice with other dentists that they're afraid of, or whether they're not afraid, or whether they're sort of will accept a patient maybe won't. The patients won't necessarily say that their gums are bothering them. It's always your teeth, but actually it's very important that we observe that their soft tissue is in the right position, and also it's healthy and there's enough keratinized tissue, and we need to do things whether we need to add more gum or take some gums away. And then we need to evaluate how the positions of the restorations and reposition soft tissue, whether that's taking soft tissue away or adding soft tissue, or maybe using some artificial soft tissue. So you'll see a whole combination of that. Presentation is all by, it's led completely by photos. This is the most text you'll probably see in any slide. And really it's about, I want people to sort of understand what I see. It's what I sort of look at when I look at a patient when they come in to see me. That I do listen intently to what their complaint is, but you'll see from from the numerous cases we're going to show, I will lead certain things. What I don't want to do is I don't want to do some treatment and then either have to repeat it in the future, or we look back and we think, oh, it's not really what we should have done. We should have done this, we should have done that. So it's up to me whether the patients accept the plan of action or not. It's up to me to present not just their problem, but other observations. And you will notice, and I did speak to Robbie about photographs, and he said that's maybe a little bit of a weak aspect of his practice. And it's the most important thing that I can do. It's the most important way that we can plan cases, as far as I can tell. We can take videos, I still want to take photographs. I'm just going to show you some photos that I take on a regular basis. And when I say it's not necessarily I'm taking them. We've a practice full of very confident and able assistants, and we really do push them to try and take the photos, take models, take and do as much as they possibly can. All the cases here today have been assessed, treated, and completed by me. If I do come across any that haven't been completed by me, I will try to say so. So regardless of whatever treatment that we're carrying out, be it restorative or be it implants or even dentures, it's important that we see where we're going to go. And this may be from a terminal dentition, because if you will notice that from all of the photographs that we take, we will get some valuable information from a tooth position, and it may be the incisal edge in a vertical position and a horizontal position. There will always be one tooth somewhere, be it a denture tooth or be it a natural tooth, that will give us some indication and a starting point for where we want the smile to lead us. Talking a little bit about photographs. It's certainly about quality, not quantity. Taking lots and lots and lots of photographs is not the answer. Please, please, if you're going to take anything from this presentation, master your photographic skills. Make sure you take the correct photographs, use the correct tools that you need, and don't take lots and lots of the same thing. Like I get lots of referrals from practitioners, and they're not necessarily the most applicable or the appropriate photographs. And then there's an excuse and things. If we just get into a pattern of taking a set amount of photographs in a set order, we will do them confidently. Store them onto the computer, store them in the right way. I organize mine not through, I use SOE through in the practice, but I don't use SOE to store the photographs. I store them on the server and in folders of the patient name, and then not just the patient name. I then create subfolders, be it preparation, implant, final, fit, whatever number of subfolders. That allows me to get to these photographs very easily, very efficiently, instead of having to go through a long list of photos through SOE. What we see here is the most common, or what I use for the photographs. An appropriate camera, lots of different cameras we can use, lots of different flashes, go through various suppliers. They're all pretty good, you know. Plastic retractors used at the correct time, an occlusal mirror, the wire retractors. This is a blackout blind for close-up photos, but you know, you don't always have to use that. So really what you need to do is you need to be using the metal retractors, the plastic retractors, and occlusal mirror, but please use them at the appropriate time, and I'll explain when. So the photographs that we take, and I will go through some of these soon. By the way, I am going to stop every sort of 10-15 minutes to allow people to ask questions. So by all means, let Robbie know he's going to ask me some questions. I'll stop in 5 or 10 minutes. So the photographs we use are pretty much from rest photograph. We like to see some incisal edge on various people. We're going to take some smile photographs of the different aspects. We'll look at that in a second. Retracted, side views, occlusal views, and really, most very important, facial shots. Facial shots are the most intimidating for the patient, the most intimidating for the clinician. They're the most important aspect, because that actually sets the whole smile up, regardless of what type of restoration we're going to create. So just looking at a nice natural smile that thankfully we don't have to do anything with. But what we see in a photograph like this is we see the lower lip, the incisal edge flowing with the incisal edges of the teeth flowing nicely with the lower lip. A nice amount of soft tissue to and show. And obviously, if we're going to do a restoration on this patient, this is very, very critical. We must get this. These photos at the top are very important. These basically are photographs taken directly from the lateral incisor, looking directly out towards the camera, not from the side, from the lateral incisor. And the reason being is because what we want to do is we want to see the contralateral canine coming in on the inside of the lower lip. And you can see that because I see enormous and lots of different cases that we redo where we see the canine coming out, sitting further out, and you don't see that necessarily from the anterior view. So this, I would say, these 3 photographs are probably the most important smile photos. But I just will take this anterior view. First of all, slide the patient's head across or rotate myself from the chair. Take this from the lateral incisor and then a direct side view. Back in again into the inside of the top lip, and exactly the same here. Retracted views, very, very important. If we set our camera up in the appropriate settings, we simply want only this amount of photo to be shown. And it's really important that we don't get ourselves into having to crop every photograph. If you take photographs correctly once without any interference with the nose or the chin or the cheeks or anything here, you don't have to crop anything, and nothing here is cropped, and I really don't want to ever crop any photograph. I would rather delete it and retake the photograph again. It's faster, it's quicker. So 2 retracted photos, one with teeth together, one slightly apart, and then some from the side. And you can take photos here with the teeth in canine guidance if need be. This is simply the only retractors that we use, the plastic retractors. These plastic retractors are only used for this view and no other view at all. So that's the only retractors, only time I will use the plastic retractors. Occlusal views, very, very important. We're using metal retractors. The reason being is because if we use the plastic retractors, they will interfere with the actual mirror that we're using. We want to have photographs that we're looking directly onto the inside of the occlusal surface of all the teeth, not from the side. You'll see some photos in a second of photographs that have been sent to me, and they're of no use to me. This is a much more beneficial photograph that we need. These are hard to take, and actually I do encourage my assistants to practice the other photographs before they start these, because this needs quite a lot of confidence to sort of bend over a patient or manipulate a patient in a certain way to make sure the photos are appropriate. Again, here we're using the metal retractors and the occlusal mirror. So this is a really, really important facial smile. This usually involves, when we're using the same macro lens on our camera, it usually involves the patient standing at a distance from us. So we have to make them stand up the other side of the room and you're standing on one side. So that makes things a little bit difficult. This is Andy. Andy is a nervous kind of guy. I ask him to smile, and I know the smile is different to this. This is somebody who doesn't want to smile. He hates his teeth, and he smiles like this. This isn't giving me any information, and if I'm given this information from other dentists, it doesn't give me the full picture. Whereas if I ask Andy to smile properly, all of a sudden it's a whole different plan of action here. So we need to look at this. The problem with something like this is a tooth and a gum problem. So we need to be very, very careful with how we approach these, and we need to make sure when we're taking these photographs that we ask these people to smile and to emphasize how important photographs are. You'll see from tonight that I'm showing you lots and lots of photographs. I think it's important for us when I'm talking to patients regarding treatment plans. I will always show them cases similar to their own. So it's important for them to give me the information. As much as I can give someone like him a treatment plan from this, I need to make sure he sees what I see. Because as soon as when I take this photograph, I can put this photograph, this facial shot, or this photograph onto the computer screen in front of him, and I can talk to him why his treatment is so extensive and so complex. These are the kind of photographs that I might get. How am I meant to do? What's the point of sending me this? Somebody sent me, give me a lower left 5 implant. That doesn't do anything for me. It's not appropriate. It's not really giving me any information at all. And look at these occlusal views. All of these, this is used with plastic retractors. Well, there is a occlusal mirror, but it's at the wrong angle. Things out of focus. Let's learn how to do things correctly. Okay, I can't plan to do an all-on-4 or an immediate load case with using photographs like this. It's just not sort of appropriate. So when I see something like this, I have to retake all of these photographs again. So a couple of bits of a few tips for you. Really get the right camera, get the settings on the camera correct. A lot of manufacturers will actually set the camera for you. Use the correct retractors. Don't mix up using the metal retractors with the plastic retractors when you should be using the metal ones. Put them in folders within a computer and use subfolders depending on if it's a patient's name. You then subfolders for whatever treatments you're going to carry out, and name the folders accurately, be it preparation, reviews, fit, final preparation, or final case, implant, whatever it is, and only take the relevant photographs. You might as well take the 12 photographs that we've talked about rather than 20 photographs when they're not actually appropriate. And you can, if you can, try and dry the teeth slightly. That really helps with the quality of photographs as well. So when we look at a case, any treatment, we all have to look at the same thing. Because when you start getting involved with more complex dentistry, it's really important to look at all of these things. So the facial midline, this is not the tooth midline, this is the facial midline. Is it symmetrical? Where are the eyes? What's the nose like? What about the shape of their face? Is it long? Is it short? Is it square? You know, these will have a knock-on effect to what the final restorations are going to look like. Are the teeth in the midline, are the proportions correctly? Are the proportions correct? Is the incisal edge correct in a horizontal or on a vertical or a vertical? Do we need to change these things? Is there a cant? And where is the gingiva? How healthy is the gingiva? Where is the gingiva? Where do we need to add to it? Do we need to take away from it? And we can't assume that patients don't want to have certain treatments. Because I see a lot of people, a lot of dentists telling me that the patient didn't want ortho, or the patient didn't want this, they didn't want that. But actually, it always seems to be the patient didn't want that. Maybe it's the clinician doesn't want the patient to have that. So I think it's very important for us to diagnose a problem and to present the problem or present the potential solutions to them. If I can deliver the solution, fine. If I can't, move it on to somebody else who can. So if we look at Nikki, Nikki is a very tall lady. We'll come back to see Nikki in a short while with regards to her case. If we look at her case, long, thin face. If you look at this close-up smile photograph, the teeth themselves, yeah, they're not sort of in line, and they're not sort of complementing her face. But if we look at her facial shot, we don't just see that her upper anterior teeth are big and bulky. We also see her corridors are narrow. So actually, even though I look at this and I think she needs smaller, shorter, more tapered tooth, she also needs her smile widened. Okay, so this facial photograph gives us that information, whereas this close-up smile photo doesn't. Really important to give us that. Whereas if we see Karen is a lady where she's a square face. We need to give her a square tooth. We need to give her a slightly different proportion of tooth. But we also can see on both of these photographs, the incisal edge is actually in the correct position. She came into me 12, 13 years ago, probably this case is, and she was upset because a dentist kept re-cementing this veneer and couldn't understand why. It's obvious that she's a grinder, and she is a grinder. But how can we, if we can try and address her wear, that's fine. She wanted to make things look nicer as well. So if I had looked at this case and I thought, okay, well, we need to make this incisal edge longer to make the tooth longer, then the teeth are going to be too long. So therefore, we need to work from this existing incisal point upwards. So we'll talk about cases like that as well. Rob, if you need to interrupt me, by the way, by all means do.
The only thing I'll say, Liam, at this point is just because you got such good clinical pictures, if people need to move you out of the way, your little screen, they can either minimize it totally, or you can sort of shift it around by clicking and dragging it, just because I know that sometimes it blocks certain photos, just so people know about that.
Yeah, and I'm probably jumping around a little bit as well, so I'm probably
all right.
So as we just going back again, sorry, thanks for that, Robbie. So we're going to talk restorative, we're going to talk implants. We're not really going to talk about dentures. Dentures are actually quite a pretty big passion of mine. I just think I'm just going to speak too long, and I operate dentures in exactly the same manner as I will do with regards to implants and any restorative work. So this is a really, really useful tool. Lily came in to me, and she wanted me to be referred back. She wanted to be referred back for ortho. She was upset with the orthodontist for whatever reason, I'm not sure why. And she wanted to get her smile. She hated her smile. But if we look at a case like this, Lily's teeth are small. So whether Lily is 15 or whether she is 55, her teeth are small in relation to her face. She hasn't had any maxillary teeth out, which sort of surprised me when I first looked at her. So I will do when I see something like this, what I will do right away is I'll just do an additive wax up repeatedly to cases like this. So we will create a wax up, and we will widen the buccal corridor, we will increase the incisal edge, and then we can add this on to her existing teeth without interfering with her teeth at all. And yeah, the wax up is a slightly costly thing, but it gives her a sort of a trial smile. So if we wax a tooth up in the way that we want to, the way we want it to look, I then can use this putty matrix off the wax up and put it over her existing teeth or her current setup on a model. And you can see that we've added bulk everywhere. We've added incisal edge. We've added some height to the incisal edge as well. And then we basically just take I use Luxatemp for my provisionals restorations, always have done for the last 16 years probably. And we can add this directly onto her case or onto her teeth without doing any damage to her teeth. All of a sudden her soft tissue starts to become involved. She's a much smoother smile. And actually I would look at this and I think she needs more than this again. So there's the advantage of looking at somebody with simply an additive wax. This hasn't been bonded in any way. This is just a snap-on smile. So you can see that all of a sudden she has a much nicer restoration. And Lily is young, but actually in reality, if she wanted to have veneers done, she is a completely additive veneer case. So it's minimally invasive. I don't think that she should go down re-ortho. I don't see the point of her having re-ortho because her teeth remain small in relation to the size of her face. So if we go into a case like this where we're going to do, well, I'll start again, sorry. A lot of cases we need to look at, is the soft tissue acceptable? If the soft tissue is in an acceptable position, we can then basically treat this case 2 to 2 using veneers. Is what we're going to do here. Yeah, you can do edge bonding, things like that there. That's fine, I have no problems with that whatsoever. But I wanted to sort of change the proportions slightly of all of these 4 teeth. So we made a wax up, and this again is simply a wax up added over her existing teeth. The advantage of what I can do then is I can then use a reduction guide, 3mm reduction guide, cut through her provisional restorations that we've bonded on top of her teeth. At this point, she wasn't numb. At this point, she is numb. I then can be as minimally as possible. There was some restoration, so we had to break through some contact points, put her into her provisional restorations, review her a week down the line, and then we will decide, do we take models, photographs, and go from there and finish the case off. This is another thing that I will do routinely, where when we go to fit the final veneer, I will section the veneer, take one temporary tooth, be it a crown, be it a veneer, take one of them off, put the final one over and see how it matches to the other provisional teeth, and then fit the final teeth. This is the day of the fit, so this is just pre-COVID, so I haven't even reviewed her, but I'm assuming she's getting on well. So if we look at Stuart had some veneers done elsewhere, but he said, you know, Liam, I can't see them. I'm really trying to smile. And he's a young guy. I can't, whether he needed veneers or not initially, I don't know. And what was happening here is that if we look at his close-up photograph, we can see that he's almost got a reverse smile. Okay. The teeth themselves, proportionally, they're wrong. Proportionally, they're too long. But actually, in a situation like his, it doesn't actually matter whether I make these longer or not. And I think that I'm not sure if the biologic width was invaded here or whether the hygiene was an issue. I can't remember, to be honest. But we just replaced these with these veneers with new veneers, and they're longer, but they're sitting much nicer in his face. He wanted me to veneer his lower teeth. I didn't want to veneer his lower teeth. He wanted me to do that. I tried to, we did his upper teeth first of all, and we tried to stay at that, but he was insistent, and what you do sometimes. But these teeth that I provide, these restorations that I provided, are much longer. In a situation like this, it doesn't matter because he has a low lip line. Saying that, you will see whether somebody's got a low lip line or not. I don't care. I want to make sure, I have my pride to maintain. I want to make sure that I get as good a result as possible. So with the so in a situation like this where Florence comes in, Florence again is another lady or another girl who she wants to have. She has been spoken about having some ortho again. But my problem with Florence is exactly the same as with Lily prior to this. If we move these teeth are still small. So we need to make sure that we give her some bigger teeth, longer teeth, but actually even though her teeth are short, the incisal edge is too long. It's too low. So we need to try and move everything upwards. So the treatment plan that I created here was I was basically going to do a gum lift from 5 to 5 and then veneer 2 to 2. We weren't going to restore the 3s, 4s, or 5s on either side. We were just going to expose more clinical height. When I assessed the soft tissue, we needed to do bony recontouring along that. I'm not showing you exactly what I did here, but I'm going to show you it on the next case for the bony recontouring. But I was quite confident these are a nice position. It's just not showing very much tooth. So here was the plan of action. So we're going to raise a flap 5 to 5, bony recontour, sorry, 4 to 4. I think it was actually 5 to 5. So we were going to lengthen 3, 4s, and 5s, also 2 to 2. But then we were going to then prep the 2 to 2 for veneers. I do a sequence, or what I will always do in a situation like this is I will do if I'm having to do some bony recontouring for teeth, I will move the bone. First of all, I'll not take any soft tissue away at all. I'll lift the soft tissue completely. I'll come back to the case in a second. And the reason why I do that is because I really don't want to start interfering too much with the keratinized tissue. I want as much keratinized tissue as possible around the final restorations. And I find that whenever I lift the flap, when I lift any flap and don't adjust the soft tissue, it actually moves back quite a lot of stuff. So this is six weeks after we've done her bony recontouring. We can see things have healed up nicely. All of a sudden, the teeth are in a much better position. All the teeth are being exposed more. And actually, at this point, she could decline the veneers and she can have ortho. I'm fine with that. I don't have a problem with that. But what we're going to do here is we're going to do some soft tissue recontouring on 2 to 2, some veneers. These are the temporaries. I sort of had to split the angles. I try not to go through the I try not to split the contact points when possible. I did here put her into her provisional restorations. Her provisional restorations are the day that we've done some soft tissue lasering around the anterior teeth. We will then see her again about 3 or 4 days later to see how she is, and then we will fit her final veneers. So a nice sort of simple case where we're exposing more of her own tooth, raising the incisal edge, moving the gum line up, and it's fine. And we're not interfering with her bite. Please don't get from me that I'm any anti-ortho. I do lots of combination cases with ortho, and I think it's a fab procedure. But I just want to, I think that it's important that me, from as a general dentist point of view, that you see the fact that I don't want to interfere sometimes with the occlusion, and actually we can work quite predictably with restoratively as well. So when we see Bethan is a challenging case, obviously, with a lot of there was an eating disorder associated with Bethan. She was also a very, very heavy grinder. You can see what you can see the masters on her. She's big. She's not big. She's wrecking teeth left, right, and center. And her dentist doesn't know what to do. I actually had placed an implant here several years ago, and I'd said to her at that point, you need to do something with these other teeth. So basically what we've done with Bethan, if we can look at her incisal edges again are very, very acceptable where they are. So therefore, in order to lengthen these teeth, we need to do some soft tissue recontour. And with Bethan, we needed to do some bony recontouring. So again, the plan of action is to raise a flap 5 to 5. We're not really going to go interdentally too much. We're just going to soften the edges. We're going to modify the shape of the bone, and we're going to put the flap straight back over again. So this is obviously one side. This is where she started. See how bulky the bone is, and you see that with a lot of clenchers and grinders, and then we're going to restore this case with full coverage crowns. So we let her heal. We see her again 6 or 8 weeks later, and we're ready to move on to the final, the temporary restorations, and then the final result. So again, we've sort of maintained, we've even shortened the incisal edge, we've lengthened the teeth, and we've got a much more acceptable restoration, or much more acceptable outcome. Robbie, do you want to ask me any questions at this point? Robbie, can you hear me?
Yeah, sorry, I muted myself. Yeah, I've got one before anyone else jumps in, I suppose. You don't, if you're doing crown lengthening, you are doing your bony recontouring at that surgical visit, and then are you putting the flat back apically, or are you just putting it back where it started? You're not doing any removal of keratinized tissue?
No, no. I did lots of cases where we would, if we did have ample keratinized tissue, we would, can you hear me?
Yeah.
I have done numerous cases several years ago where we would have adjusted the soft tissue with if we did have ample keratinized tissue and the bone at the same time, and put provisional restorations on at the same time. I just found that the soft tissue didn't heal as nice as it does now, because I think whenever we lift it from their own natural teeth and then put it back again on their own natural teeth, we can then move on to the final restorations much quicker.
So do you put the flat back virtually where it started, and then let the gum margin find its own level?
Yeah. Probably, I say 6 weeks. I'll leave it 6 weeks, and probably in reality, I'll leave it 8 weeks before. But I mean, more often than not, you will still have to do some gum recontouring at that point. Plus, I'm fine with that at that point.
Anyone else, feel free to unmute if you want to ask anything.
No.
No, far away.
Okay. So implants are probably, people who know me probably think that I'm passionately all implants, and I do like implants, and I do place lots of implants, and implants aren't just, they're a tool. They're not the answer for everything. They're really not the answer. And I've got a root filled tooth in my head, so I don't think that endo is by any means something that we shouldn't be doing. And you know, it does concern me when I see patients coming in to see me who need complex restorative work, and I'm sort of either having to leave a post in place or an uncertain root filling, or there's no core. It does concern me, and I'm debating with myself, should I be taking that out and putting an implant in? And sometimes I get it right, sometimes I get it wrong. I don't know. But with regards to the implants, probably the most challenging implants that we'll look at are single implants, because if we do a single implant, it's not just, people aren't coming out, they come in and they ask us for a tooth, but actually in reality they're not coming in to have a tooth, a natural looking tooth taken out and put a natural looking implant back in again. There's more often not damage to the bone, damage to the gum, damage to the tooth. So can we put the implant in straight away? Can we not put the implant in straight away? It's really, really important that we do it and we think about it and we do it in the right, correct manner. So people who are involved with implants, just be very careful with how you select some of your cases. And by all means, if you ever wanted to ask me about if you should sort of tempt something, I'm here. I'm happy to help whoever. So with regards to the single implants, the options we have is, if we have a failing tooth, do we take the tooth out right away and we put it in on the same, put the implant in on the same day? And if we do put the implant in the same day, do we put a tooth on it in the same day? Because there's reasons for doing both, for not doing it and doing it. And then if a tooth is infected, do we leave it out, or maybe do we take a chance and put the immediate implant in and treat the infection at the same time? And then obviously we have to treat existing heel ridges, because a lot of people will come into me and say, I've had a tooth taken out a couple of months ago or last week or whatever, and we need to put the implant in when it's healed. And then there's multiple implants, and then full arch implants. Full arch implants is basically as what they say, but every case, as you'll see, is different again. So each and every case has not got one fixed treatment plan. They all need to be assessed. Photographs are the key to this. So here's a situation where this is a post-crown. This is a fractured post-crown. Post has to be, so the tooth has to be taken out. But it's a high lip line. We need to make sure that what we're going to try and do is we're going to try and maintain the soft tissue. And in fact, what we want to do is we actually want more soft tissue. So I look at a situation like this. It's going to be a very predictable result, but what we must do here is we must take the tooth out, we must put the implant in straight away, and we must give this patient a provisional restoration on the same day. No dentures, no no temporary bridges of any kind. In order to maintain the soft tissue and gain soft tissue, we need to address that from day one. So it's very important. So we're going to take the tooth out cleanly, gently, slowly, okay, using elevators. We'll put the implant in more platally. It doesn't go into the socket. It's always angled towards the platal aspect, so there is always a space here. We will pack the area with bone to allow new bone to form. We will lose some bundle bone along the buccal aspect. So in a situation here, what we're doing is we're actually putting in a provisional post. So into the implant itself, I'm going to put a provisional plastic post, and then connect, and then we'll put a little bit of rubber dam across the top. We'll put the impression that we've taken initially. We will put that back over, allow that to set over this. Remove this. It looks very uneven. So this is the same post, this white bit. This is the Luxatent, uneven, not contoured yet. And this is just a dummy implant so I can hold the respiration. What we then want to do, and we want to imagine the tooth here and the soft tissue is going to come out here. What is really important is that we create a big bulbosity along here. Because if we create a nice cuff of soft tissue, that will create stability for keratinized tissue in the long term. So we will add some flowable composite, reshape it with soft like this and burrs or whatever, glaze it, and then leave this. So if we can imagine, this is where the emergence profile is going to be. This is all going to be soft tissue from here. If we have this, if we make this too bulky around here, that will make the soft tissue fall back. So when we put the provisional crown in place on the day of surgery, the gum has been lifted, it's been pushed back more by me taking the tooth out. But what this photograph doesn't show is that at this point, the crown has started to be beveled backwards. So we see this patient 1 week later. This is where the soft tissue has come to. So we have got better papillae, we've got a better profile. We probably need a little bit more healing, but we'll leave that in for 3 months. It's a non-functional tooth. It's not inner bite. It's taken away from the platal aspect. But this is an immediate placement of an implant with an immediate temporary screw-retained crown. Very important to be screw-retained. We do not want cement in under the margins on the day of surgery. And this is the case here where it's been a 3-unit bridge. We were going to look, we see photographs, we see the fact that actually we're going to convert this into a crown, an implant. We're going to put a veneer today. I'd probably put it to some composite easily, but we're just going to put a veneer on it at the time. But in order to get rid of this, we need to take some gum. We need to take a soft tissue graft. So we'll take a soft tissue graft from this palate, we'll put the implant in, we'll put the soft tissue graft in on the buccal aspect of where the implant is. We've also done some bony recontouring on the canine to make sure we try and expose this. We only see these things from photographs when we take smiles. And then the reason why I put this photograph in is because look at how thick the keratinized tissue is along here. That's stable. We are going to lose some buccal bone when we do an immediate implant placement, but look at this tissue. It's thick, it's stable, it's not going to move anywhere very quick. And then we end up with a final result. He wanted to keep this, I love this case, he wanted to keep a gap in the middle. Who's ever going to tell if this is an implant and this is a veneer and these are crowns? This is a very nice result. I'm very happy with something like that. And even a situation like this, where this canine is actually infected, so there was a buccal sinus in this. These two teeth were implants, and so the option was, will we take the crowns off the implants and put a provisional, or we'll put a bridge from the 4543, which could have been an option, but we decided no, she didn't want me to touch these implants, so we're going to take out this fractured tooth with the infection. Again, the implant buccally plately placed, sorry. And when that's placed, I will have degranulated this socket. And we're actually, in order to try and preserve the keratinized tissue around the preserve the keratinized tissue, we're going to just raise a semilunar flap to expose with infection walls. Then graft infection, leaving this cuff of soft tissue, leaving this bridge of bone as well. And then we can put, and then we suture up, we'll put bone graft material onto that, and a membrane over that, and then we will suture up, and we've left the soft tissue in place. I mean, actually, when I put the provisional restoration in, you can see I've left this intentionally loose to allow the soft tissue to fall back down again. Okay, but a situation like this doesn't warrant having an immediate placement. We can't do an immediate placement. If I look at this case, I think we can get, and I'm always very confident we can get a really good result with this. We've got no keratinized tissue. There's this soft tissue has been insulted for years, for many years. She's embarrassed by this, obviously, and doesn't know what to do. So what we look at in a situation like this is, number one, we need to try and give her some more keratinized tissue. We'll talk about that. I don't like to give these people dentures at any point, but I think we're going to get a nice result, because at the minute we do have a space here, but we've got the soft tissue on this central side is quite good. The papillae on this lateral is also good. So we should be able to maintain that and gain some keratinized tissue along here. Okay, so we take the tooth out. We are then going to take a free gingival graft from her palate, and we will move this in. And in reality, to be honest, I'm not sure if I needed to do this. This was done 10, 15 years ago probably, and I'm not sure if I actually get any benefit by doing this. I think if I had maybe left that out just as it is, that would have healed with keratinized tissue. So I don't know whether I did, but anyway. We then fitted her with a little Rochette bridge from two to two. Left it probably 6 months, allow the soft tissue to heal, but now all of a sudden, look at this case now in comparison to initially. So we do a conventional implant placement. Excuse me. We do a conventional implant placement with some bone grafting material, and then we put an abutment and final crown place. And that's a nice, simple, easy, straightforward result. And I'm quite confident in time that things will result. Well, I think in time, this papillae will fill in. It isn't there, but I think because we've compressed the tissue, I think we'll get it. We've got good interproximal bone between the implant and the other central. And this is a situation where we don't want to get ourselves into. So when we have this young 21-year-old comes in to see us, another dentist has her grandparents give her the money for 2 implants, congenitally missing laterals. Give her money for 2 implants, and she is distraught when she sees it. She hates it. She doesn't want it. But this is a situation where, when we look at this case was not planned properly, because obviously when we plan this case, we want to have the gingival margin higher than what these are. The added problem for Abby is that the implants were actually slightly supracrestal. So to try and push things back is even harder. And also the implants were close to the neighboring teeth. And at this point, money was an issue, because she couldn't afford to do very much, because she spent all her money on this, and she was distraught with it. So really what I did is I just sort of lifted it. I said, look, I don't know if I can do this. I'm going to try and push the gums, laser the gums back a little bit, and then we will put on a new abutments, new crowns in place. We did this. I think we were quite lucky to get away with something like this here. But this is a much more pleasing result. You can see where we end up. There's still a big void. This needed more bone grafting higher up. The bone grafting wasn't done in the first place, and you can see the shine through of the implant. At some point in the future, what I may end up having to do is put some artificial soft tissue underneath her gum. That might give a nice result. Finances were an issue, and I can't really bring these gums up any higher. So all I did really for Abby was take the old crowns off, put new abutments on, recontour the gums as much as I possibly could. I would have liked to have gone a little bit higher and then whitened her other teeth. I'll just talk about this one, Robbie, and then I'll stop again, okay? This is a case. If you see a case, I guess, don't treat them. It's too complex. This is Mike. Mike is a very, very heavy grinder. You can see that he basically came in to see me with composite crowns bonded together, because these were fractured, these had posted, and this is a situation where he came in. So how do we manage a case like this? These are very, very complex. He admitted himself, he grinds, and he messes with his teeth. And what can I do? So should we do endo and put more post crowns on? He was having none of it. So really what we did was we plan to take the teeth out and put immediate implants in place and then put some temporary teeth on straight away. But when I tell you now that if we take teeth out and we leave the papillae, if we take the teeth out and don't put the implants in and don't put provisional restorations on the implants, we will lose these papillae. And he is a low lip line, but I don't care. I want to make sure that I get as nice a result here as possible. So what we need to try and do, or what I thought here, what we should be doing here is we could sequence this treatment where we could take one tooth out and another tooth out and then put an implant in here and then sequence the implant treatment, and that would be very acceptable. But what I did was I extracted these 4 teeth, generally speaking, and we were going to keep this canine and put a new crown in this canine. What I would usually do when I look at a situation where there's a 5-tooth span of these teeth, I look at key sites, and the centrals and canines are always the key sites. So if they're missing 5 units along the front here, we would usually put 3 implants, 2 in the centrals and 1 in the canine, and bridge the laterals on both sides. Because of the history, I put in another implant in him. So we basically put 4 implants in, 1, 2, 3, 4, just to over-engineer things a little bit. We're then again going to put on provisional abutments, provisional plastic abutments, and make up a provisional bridge. Fit the provisional bridge, leave things alone for 3 months, try and take this out of occlusion as much as possible. I can't take this out of occlusion completely because of obtrusive movement. So this take pressure on day 1. And again, we take these out 3 months later, and we see how nicely well preserved these they are. Believe me, and anybody who's done implants, they know and they understand this is not an easy thing to do. If we had taken the teeth out and left them out with a denture, he would have lost all of this, and we would never be able to recreate that. Put in the final bridge and crowns, and we're done. And we've been good from then. Then this guy needs a mouth guard. Does it really matter that he kept the papillae? He's got a low lip line? No, but I wanted to make it as nice as possible result. Robbie, any questions there?
I've written down. Just a technical question for me. What glaze do you put over your Luxatemp for your provisionals?
It depends on whether I pick the right shade or not. If I pick the right shade, I usually put on Prime and Bond. If I pick the wrong shade, I'll put on Luxaglaze. Luxaglaze tends to tone it down a little bit. I would say that when I go and travel to practices and I ask for provisional rest, or when I ask for Luxatemp, I'm always seeing A2 and A3 shades, but actually I would never, well, not never, but I would very, very rarely put on an A2 shade on anybody, and I'm not sure if I've ever put an A3 on anybody. I do think if I put on an A1 and it's too light, Luxaglaze tones it down quite a lot. But generally speaking, I'll try and get the right shade and use Prime and Bond. Soft like this, polish them up nicely.
And in terms of your workup for these cases, are you using face bows for anything more than a few units, or what's your kind of?
I use face bows for like this case that's on the screen now. No, I'm not using face bows for this. No, I'm using face bows for more of the complex, more of the sort of full mouth combination cases.
And then the last thing from me before anyone else can hopefully contribute is the girl with the congenitally missing laterals. Are you worried about the prognosis of those implants long term?
Am I what, sorry?
Worried about the prognosis of the implants long term?
No, I'm just worried. I would be more worried about the soft tissue around the implants. I think the implants have been in a couple of years at that point. I think the implants will be okay. But, you know, she knows that I can't guarantee the implants in any capacity because there was multiple issues with them. They replaced 2 buccally, they replaced 2 coronal.
Yeah.
There's no grafting done around the lateral incisor or around the regions either. So there's less tissue. So I may go back in there with something like Mucoderm or something and pad out the soft tissue.
Would anyone else like to ask anything?
Don't be afraid to ask. Come on.
Yeah, come on, guys.
Right, let's move on to this, and Robbie, okay?
Yep.
So this is a typical case I will see day in, day out. Somebody comes in with had teeth taken out a few weeks ago, hates the denture, can't cope with the denture, wants rid of the denture ASAP, and doesn't care. When she presents, she is not complaining of, she's not complaining the fact that she has got, she's only complaining the fact she's got false teeth. She's not mentioned anything about how she looks. She's not even mentioned that at all. So it's really important that we take photographs, and I put this photograph especially on the screen, and I say, okay, I can give you two teeth which look like that. If I give you two teeth that look like that, will you be happy? And if the answer is yes, then potentially we can go ahead and do a couple of implants here. But we can look at the laterals, both laterals, especially the right lateral, and say, okay, actually we're not showing enough, or showing too much gum in relation to the other one. We need this to be symmetrical. It's also over-erupted. Your lower anterior teeth are also over-erupted. We need to maybe consider doing some ortho to try and align these better. So basically, so when we start sort of showing cases, or start showing this type of photograph, they go, all right, okay, well then what else can you do? So this, she declined the ortho. She wasn't interested in the ortho. I think this should be an ortho case. It wasn't an ortho case. But even if she was going to have ortho, I don't think I would put her back. I don't think I would have done ortho in this case on the upper lateral. I would have just treated her the lower with ortho in the lower arch, and that was it. So we did some soft tissue reshaping on her upper arch, and a couple of implants and a veneer on the other side, and ended up with a nice simple result like this. Much nicer result, and all of a sudden the teeth that we don't even notice at the back actually sort of sit in quite nicely, and the incisal edge is slightly lower. So it's all dictated by how the teeth are presenting. And again, we're going to look, and we're going to dictate this by the photographs that we take and we present to them. And also the photographs are helping me decide what to do as well. Because even though I might speak to her and I might see this, it's also becomes very apparent to me when I'm sort of seeing the photograph, be it with a patient sitting in front of me or not. So look at the way her smile changes. Look at the way the corners of her lip changes as soon as she starts licking her teeth. This is a nice simple result. Two of the crown and the gum lift crown, two implants, two crowns, and a veneer in the lateral. So this is Jackie. Jackie is been patched up and is fed up. She wants, and you know, guys, we've got lots of patients, I guess, in our practice. I see them a lot. And if we look at cases like this, people don't want to be like this. Her upper left tooth is bigger than any other tooth. Her upper right tooth is bigger than her central. We need to change these proportions completely. So we want to look at a situation like this and go, okay, how can we make things different? So if we change the proportions of our laterals, we can, if we reduce this lateral, we can then increase the centrals and reduce the upper right lateral to allow the other centrals to be bigger again. So when we look at a case like this, this is her X-ray. We have also got an infected upper left floor, and we've got low sinuses. So I will look at this in sort of two different phases. Number one, we are best to do an implant retained bridge. Either do endo here or take this tooth out and do an implant retained bridge. Needs a sinus graft and an implant and sinus graft on this side, be it a provisional bridge or sorry, a Maryland bridge or a conventional bridge or whatever it is on here, or an implant. That's fine. I'm not debating about what we need to do in each of these cases. But if I look at this situation and look at the top left-hand side, the plan of action here is we're going to take this tooth out. We're going to put an implant in here. We're going to put a provision, or we're going to do a sinus graft, and we're going to put the implant in. Okay. So on day one, I want to try, and what we need to learn when we go back to work again is we need to try and make sure that we do as much work as we can on each visit that we see patients. So the plan of action here on one visit is going to be the implants on whatever implants we need. But we're going to do the implant here with a sinus graft. Take this tooth out. We can take this tooth out and leave a gap, or we can actually prepare this for what we're going to do a crown in the future and make a little provisional bridge just to cover the gap a little bit. So that's what we're going to do. So on that very first day, we start treatment. We take the 5 out. We prep the 4. We're then going to raise the flap, expose the sinus, raise the sinus membrane gently. We're going to clean out the apical infection on that. We're going to do a sinus graft. We put an implant in. We then can put a membrane over, And then she ends up at the end of her first visit of the first phase with an implant, her definitive abutment on the implant. The tooth has been taken out of the floor. She's in a little provisional bridge on here. That's day one, and we've done the implants on the other side. And that then is left alone for a period of time. We can leave the whole case for 3 or 6 months, whatever length of time we need to leave it, or we can actually move on to the anterior case, and then we put her into her provisional teeth. Much nicer case, much nicer setup now, and then we can move on to the final result and give her her final teeth. So that's what I would do conventionally with full art or combination cases. And I do a lot of cases like this where we're having to phase things out quite a lot. But I do try and keep them out of dentures as much as possible. I don't like having dentures sitting on top of healing gums and implants and all of that. So as much as possible, I'll try and stay away from dentures. So moving on to full arch implants. So full arch implants is basically where we want to have a whole entire arch of implant supported bridges or bridge, whichever we decide to do. So the conventional implant treatment will be taking the teeth out, putting somebody into a denture, and then putting implants in, keeping them in the denture for a few months, and then connect the teeth to the implants. So that's probably a 12-month plan. I don't do that pretty much ever. We can go through a sequential extraction route, or we can go through same-day teeth. So all these different situations need to are warranted to have a different plan and a different lookout. So even a case like this, where obviously teeth need to be taken out, we're not going to look at a case like this and say, okay, you have to get in the conventional implant treatment. If I do a same-day teeth procedure and the implants aren't stable, I will say to them beforehand, you may leave with the denture. That very rarely is actually only happened to me once. But if we look at a case like this, where this is all periodontally involved, and these do all have to be extracted, I'm going to try and maintain the soft tissue as much as possible. So if we look at this case, the plan of action, is to put the implants into the centrals, the canines, and either the 5s or the 6 regions. So in a situation like this, we're going to actually prep the 2s and 4s on both sides. And this is actually an existing implant. We're then going to extract the other key sites and place implants in immediately. And then we're going to put a provisional bridge based on a wax up on these four temporary retainer teeth. Again, look at the way I've reshaped the gums or reshaped the provisional teeth to make sure that the soft tissues fall into place. We then see 3 months later, soft tissue is in much better position. We are then going on to second phase of extracting those 4 teeth, putting on some temporary abutments onto the 6 implants now in place. And then we will extract the 4 and we'll put her into a new temporary bridge based on this, similar look to this, will allow things to heal. Leave that alone for about 8 weeks, allow things to heal nicely. The implants have been in for 3 months, so they're nice and stable. Contour the pontics very nicely, and this is the kind of result we can maintain. Okay, and then take impressions or scans or whatever we want to do. She wanted white teeth, she got white teeth, but we were able to maintain soft tissue nicely. Whereas the same-day teeth concept, it's a very different concept to the sequential extraction of the conventional treatment, where it's basically the all-on-4 concept, where we take teeth out, we put in whatever number of implants there are, maybe 4 implants, maybe 6 implants, and then we tend to angle the implants quite a lot. We tend to angle the implants, but then we put angle the buttons in place to make sure that we upright the implants and making sure that the patient leaves on that very same day with a screw-retained acrylic bridge. Okay, we then replace that bridge or bridges 3 to 6 months later, depending on healing. So Nikki is a case where we're going to do same-day teeth on. Unfortunately, she was gone for years and years and years of hygiene, good hygiene. You can see someone like this she has hygiene is very good, but you know, she's just fighting a losing battle as far as I can see. And I'm not into somebody in to try and retain these. I look at this and I think, okay, you know, we have a good bone here. We are taking CT scans for all of these cases, or for lots of these cases. But look at this as the case that we looked at initially, where I think that we need to fill out her buccal corridors quite a lot. We need to also reduce the size of the anterior teeth. And make her more of a temper, or make her teeth look more tapered. But at the same time, I'm not going to trust her soft tissue. I'm going to get rid of the soft tissue and bring in some artificial soft tissue. And in order to do that, I have to take away, there is deep pocket in here, but I will still have to take away some bone. So we'll do a clearance. We will raise a flap 6 to 6, 7 to 7, whatever we need to do. We will flatten the ridge to the desired position. You can see the angles of all of the implants. So all of the implants are placed in at different angles. Even the anterior implants are placed angled. they're angled more buccally, because we're trying to engage the platal aspect of the platal bone. Sorry. We will then place these low profile or these multi-unit abutments, which will allow the screws for the bridge itself. Which this is a template of the bridge that we're going to put in place. We will angle the abutments to make sure the screw access hole comes out through the platal aspect of the teeth in this case. More often than not, we've got an excess of soft tissue around the palate. We will have to just take away this excess tissue, because the bridge is going to compress on that. She leaves on the first day with these fixed upper and lower full arch bridges. I will do, if I need to do an upper and lower case, I want to do it on the same day, be it with or without sedation. So on the day that she leaves, this is how she leaves on the day. This is actually probably a review a few days later, but these are her 8 implants in place. They're all loaded on the same day, and you can see that all the implants are these. Certainly the posterior implants in the upper arch are angled, but these are also angled, but they're angled coming out through the buccal aspect. When I look at a case like this now, I'm looking at her a few months later, and when we're going to do a final restoration, I know that Nikki is a tall, thin lady. These teeth are too big, too bulky. We need to show a little bit more soft tissue. So we want to make things as efficient as possible. So on the day, the first day, 3 or 4 months later, when we go to restore this, this is a model we've taken on the day of surgery, and we've had the technician to make up this jig. Because what we have is we have the reference of where the implants are we know where the implants are, but we don't know where the soft tissue has ended up. So we will take the bridges off, we will put this jig in place, we will take an impression. So now what we have is we have an impression of the implants and soft tissue in relation to each other. So we can now make her definitive bridge. But we will also take a copy of her existing denture, or her existing bridge, sorry, and we will make the comments to the technician. How do we make things look different now? Because I'm dictating to him to say, yeah, the buccal corridors are filled out nicely, but I think the teeth are too bulky. She's too tall and slim to have more of these teeth. So this is her final try-in, and we're happy with that. And then we go and we finish her case off. And the teeth are much more narrow in appearance. Incisal edges are sitting in a nice position, and that's a nice little result. She looks much nicer than when she started. And she's a very pleasant lady when she first came in, but she's a very complimentary patient to us now as well, and she's absolutely thrilled. These are expensive things, but you know, I'm not there to create budgets for people. I'm there to deliver a product, and this is the kind of thing we can do. So hopefully you've seen what I've been able to. I'm quite passionate to make sure that whatever we do, we make it look nice and functional and healthy and long lasting, because the last thing I want to do is I want to repeat dentistry. It's too complex. I don't want to fall out with anybody, any patients, and we need to make sure that they see before we start what their problem is. Because I will always say to them, this is your problem, this is my problem. I'm here to sort of tell you what the problems are. So if somebody's missing a couple of teeth, it's up to us to look at the bigger picture. Photos are the huge photos. You've seen, I take thousands of photographs, and the girls in the practice take tons of photographs as well. And it's really important that we keep taking photographs, because it's good. And don't take photographs sort of before, during, and then not after. Be proud of it. That's I don't mind if people are critical of my work. You know, I'm critical of my work, and I've shown you work, and I haven't cropped or photoshopped anything at all here. So these are the photos I've taken. And I'm just a little bit, because of we're in the position that we are, this is my observation with regards to what I think we need to do. At the minute, I am in charge clinically with patients. I do, if I don't want to do something, I won't do it, and I'll say, no, I'm not doing that. I would rather patients go elsewhere than I do something that I don't agree with. I do tend to work with two nurses. I've got two surgeries going at the same time and a treatment coordinator. And I think that's probably not a bad way we will work in the future. And I think actually if we need to have downtime in our surgeries, you know, if we do all have to go back to more of a rota type basis, you know, working in two surgeries doesn't mean we're running from one surgery to another. It means that we've got multiple nurses, multiple people working, and actually it allows the clinician and us to move on efficiently with our time to see other patients. And I've done this sort of for years. I could imagine that I will probably work out of 3 rooms in the short term, because I think it's going to take there's going to be a lot of downtime, as we know. But we want to move on. We want to be as efficient with our time as possible. I'm a little bit worried about what going back. We've been off for 2 months. I'm sunburned from today. I'm sunburned from playing crap golf and whatever else to do. But you know, it's been a good time, and we're going back at some point. And I think people who actually do good quality dentistry are the people who are going to survive better. So if I was to give anyone any advice, I would try and follow an aspect of dentistry that you enjoy. Make it whatever stage of your career you're at, be it a couple of years qualified. I remember when I qualified, and within a couple of years I was off traveling here. Then everyone, my friends were telling me you're crazy. And I was like, no, I'm just doing this. I'm doing this. I like this. I did a lot of cosmetic dentistry. Then I did a lot of started implants, and then I'm combining the two. And I think it's set me in good stead for me going forward in the future. That's all I have to say. I hope you enjoyed that. I hope you got something out of it. I'm more than happy to take any questions that are come my way, but if nobody's anything to ask me, then fine. So over to you, Robert.
That was awesome, mate. Thank you so much. Thanks for your time, you know, putting that together, because there's a lot of effort gone into making that presentation and documenting those cases so well and explaining things so clearly. So thank you very much.
I hope everyone understood me.
Yeah, you're
We did.
Not that bad, don't worry.
Thank you very much, Liam.
No problem at all.
Great stuff.
Any questions there,
Yeah,
Robert?
does anyone want to chip in and ask? It doesn't necessarily anything about the cases or anything about Liam's surgery setup or the way forward, or just anything anyone. Let me see if I can switch this over.
Somebody asked me something. Ask me how much something is.
How did your round of golf go today?
Better than yesterday's. I still lost about 7 balls.
It's not bad.
How was the tennis the other day?
You what?
How was your tennis?
Oh, sorry. Yes, I see you now, Rachel. My tennis is poor. My tennis has always been poor, but
Perfect time to get better.
well, I know. Not with my gammy back, it's not.
Ronnie's asking about the wax up temp clip on. Do you just make them off the model and then try it straight into the patient?
Well, when I get a wax up back from the lab, I will ask for a plaster copy of it as well. So that comes back automatically to me. And then I will tend to either they will send me they will send me back a putty matrix, or I'll make one up myself. I actually quite like to make one up myself, and we will use a separating gel on the plaster model. I will put in a hard body material into a perforated tray and just put it directly on top of the plaster model. So over the plaster model of the wax up, over a copy of the wax up, I'll I can't remember what the thing's called. There's a separating gel, and we'll just basically put the hard body straight on top of that in the tray without any glue whatsoever. Let it set, take it out. Then I'll put some light body around the teeth and a little bit within the putty itself. Set that back into the wax up copy. Take that out. I'll then separate I'll take the putty itself out of the tray, so I can actually use it. I've got a hard base, but then I've also can sort of take the base away if I need to. And then on top of the teeth, I'm not in that case. I showed with Lily, I didn't bond anything on whatsoever. I let it set on for 1 minute. take it off, trim it out myself, and then put it back into her mouth. So the nice thing with something like that is I'm doing that when she's not numb, and you can sort of see her smile, and then it's a little bit of a trial run for her as well on that same day. But don't be afraid to charge for wax ups is one thing. I mean, I would say that a lot of people will say, well, actually, I don't want to. How much are your wax ups? And a wax up like that, I'll charge probably 400 quid for it. And it's worth every penny of it because it needs to be good. I think I charge about 40 quid a unit or something out there for a wax up, or maybe more. But it's a template of where we want to go. But I don't just rely on the wax up. It's not just the wax up, because I certainly will. I will sometimes add some flow.
It came up soon.
Okay.
I'll sometimes add some flow onto the teeth to give some feedback,
Doesn't seem to.
recognition of where I want the incisal edge to be, for example, and then that gives them the information. I'll always sort of prescribe to them what I want to do with the midline, exactly where I want the incisal edge, and some feedback with the midline, obviously, and the buccal corridors. I quite like sharp looking teeth, sharp line angles on teeth.
Chigs is asking, how do you price treatment plans where you've got multiple teeth of unknown prognosis?
That's probably one of the most difficult aspects of what I do, I think, because sometimes I am worried about, sort of, as I was saying before, do I rely on a post crown that's there, or do I rely on a root filled? And I think nowadays I'm sort of more going towards sort of, I will go through every tooth and I'll put a tick by it, or I'll put a question mark by it. And the ones I put question marks by, I'm taking out and putting implants, or I'm doing bridges or something. So I'm becoming a little bit more critical. I do have a disclaimer for patients to say that, you know, if you've had a previously root filled tooth, or if you've got a post in there, I can't guarantee that this restoration we're putting in place here is relying completely on what was there beforehand. And, you know, patients, you know yourself what patients are like, they'll say, well, actually, it's not causing any problems at the minute, but actually, if it does cause a problem, be it 5 years down the line, it's my fault, even though it may not be my fault.
Yeah. If you go into all that effort and patients go into all that effort and cost for it to be...
yeah, and I'm not saying that implants are the answer for everything, because they're not at all. They're certainly not. But and I do retain old root filled teeth as well as having teeth root filled. You can see some cases that I'm restoring on to root filled. If I do see root filled teeth and there's a decent core, I'm always putting a fibre post into it. That's without question. Whether there's lots of core there left or not, I'm putting a fibre post into them all. But if there's a tooth which is fractured gum line, I'm taking that out and putting an implant in.
Great.
Anyone else?
Just to say about, I'm going to send a little survey monkey. It's literally like a 1-minute feedback form, but it'll be helpful for me and for Liam. And it'll mean we can give you a CPD after this. You can either get it by that QR code if you've got a phone handy, or I will send a proper link out via the email later on.
Can I ask one thing, Robert? Can I ask people just to be really honest? I can take criticism. I won't get upset.
So yeah.
Oh, if it's anonymous, then don't tell lies. No, honestly, I'd rather be truthful, because I do want to be as relevant to people as I can.
Yeah, well, it helps everyone, doesn't it? You know, and there's a question on there for sort of potential additional things going forwards, either simpler, more complex, different things. Liam's kindly said that he's happy to do more talks in the future, and certainly I am as well. So if there's anything people want to talk about going forwards, we can put more on if there's an appetite for it. So, like I say, just let us know.
Definitely, yeah.
But otherwise, we'll call it a day.
Okay, well, thank you everyone for your time. Hope it didn't ruin your evening.
Thank you very much. Your time, mate. It's been great.
Yeah. Cheers,
Thank
guys.
you very much.
Robbie. Thanks, Liam.
Yeah,
You're
thanks,
very welcome.
Robbie.
All the best, everybody. Thank you very much.
Cheers, guys.
Cheers, guys.